Last session before lunch is valvular heart disease, advances and treatment choices. First one, Dr. Kleiman. TAVR for aortic stenosis, is it for every patient?
Good morning again. So look, two things. Let's start off fast. TAVR used to be called TAVI in the US. In the rest of the world, it's still called TAVI. We learned pretty quick that if we didn't use the word replacement, we could never sync with Medicare's payment schedule, and we wouldn't get paid. So that's number one. I'm going to talk a little bit about money at the end because it's important in this regard. Number two, when you're asked, is it for everyone? If they ask that question, the answer is obviously no. So let me help you out getting through that. Of course, in the conditions, they changed the pointer. Let's see if it worked. All right. Okay. So number one, the growth in TAVR over the past 5 to 6 years has been phenomenal, well beyond what anyone ever expected. And the reason is it's become easier to do. And, the truth is we've become better at it than we ever thought we would. If 10 years ago I said to you, we're going to take an aortic valve that, surgeons implant surgically, they take very carefully out of a box, soak it, then very gently place it into an aortic annulus. We're going to take this thing, we're going to twist it, crimp it, coil it up on a catheter that's, about the size of your pinky, and then put it into this calcified aortic valve, blow up a balloon inside it maybe once, maybe 3 or 4 times to fully expand it, and then it's going to work. You'd be laughing at me. But in fact, it worked, and it's turned out to be very disruptive, meaning it's changed the way we think and the way we do things. Here's our own experience. You can see this growth has been astronomical, and that's within a limited patient population. So one of the issues is going to be, is it going to expand to a broader patient population? And that's not an easy question to answer. This shows you what's happened in our own experience. You can see as we started TAVR, there weren't very many places doing it. We attracted patients who might not otherwise have received attention to the aortic valve. And so the number of surgical replacements actually increased. Now you can see proportionally that's changing, and TAVR is competing with surgical valve replacement. Now, to what extent will that continue? That's what I'm going to talk about. So just to show you what we do, we heard a lot from the imaging guys a few minutes ago. We're very dependent on them. So when we screen a patient, we go through largely a CT evaluation, assuming that they meet the clinical qualifications, asking, do we have a valve that fits? If the answer is yes, we've got a lot to think about. If the answer is no, it's really straightforward. If we don't have a valve that fits, it's either surgery or medical management. So here's what we do. We measure the annulus where the valve will fit. Right here, we measure either the circumference or the area, make sure that meets the specifications for one of our valves. Most importantly, after that, we measure the sinuses of Valsalva. Are they going to be big enough for us to implant a valve without occluding the coronary arteries? And sometimes that affects the choice of the valve. Sometimes that affects our decision. In addition, in 2017, if we're seriously debating between surgery and TAVR, the size of the annulus, which will determine the size of the surgical valve or TAVR valve, may shift us from surgery to TAVR. When surgeons implant small surgical valves, they end up with high gradients. There's some debate as to whether that's a problem or not. Most of the thinking is that it is. So patient who's equivocal, small annular size, pushes us toward TAVR. We also measure the iliofemoral system. This is our This is our highway to the heart. This affects whether we can do transfemoral valve implantation. Sometimes it may shift us to a non-femoral implant procedure. That's got higher morbidity. Whether that can be done or not may affect whether we perform a TAVR. So those are some of the operational choices we make. So just, showing videos in my field is a sign of manhood. So I got to show you some videos. This is what we do. This is a self-expanding core valve. We slide it down to the annulus, which is just below the marker pigtail. And then we release the sheath that sits over the valve. The valve expands, as shown here, and is then released. Unfortunately, my second one doesn't play, but what you would see is this sheath coming back. You see the valve starting. Is there any way you can play that from back there? You would see the valve starting to expand and pop open, and then it would be released. We'd bring the sheath back. Can you play the second one?
On the right.
On the right. We'd pull the sheath back. You'd see the valve fully expand and sit in place. So there are a lot of data now, and I'm not going to painstakingly take you through it because it's pretty clear. There is not much equivocation here. In inoperable or extreme risk patients, there's no question. Placing a valve beats medical therapy, whether it be a balloon expandable sapien valve or a self-expanding core valve. Sapien was partner cohort B, randomized the sapien valve versus medical therapy. Hands down, valve won. At 5 years, one patient in the medical group was alive without having had a valve replaced. One. Core valve extreme risk went up against a performance goal based on partner findings, found something very similar, no question. So these are patients for whom the surgeon would look at me and say, you want me to do what with this patient? What about when the surgeon says, well, I can operate, but the risk is going to be high? Well, that's been studied too. 2 trials randomized against surgery. Partner cohort A, again, sapien valve was equivalent to surgery out to 5 years. Core valve high risk was actually superior to surgery in terms of survival as well as stroke at 3 years. So in this group, there is evidence of equivalence, possibly superiority. Catheter valve wins because it's a lot easier to go through. Intermediate risk for surgical AVR. So this is where the surgeon will say, yeah, risk's a little elevated, but we can do it. Partner trial, equivalence to performance goal. Certavi out to 2 years, equivalent, rather superior. Equivalent at 1 year, superior at 2 years to surgical AVR. So what does risk mean? Well, currently, according to the way the trials have been done and according to the way CMS has dictated that they want this done, judgment by one interventional cardiologist, who's obviously worth the weight of 2 surgeons, shown here, that risk categories are as follows. Extreme risk means greater than 50% risk for mortality or irreversible morbidity at 30 days after surgical AVR. High risk, 15% risk for mortality, but less than 50% risk of death or irreversible morbidity at 30 days after SAVR. Intermediate risk, defined as 3 to 15% risk for mortality. How do we get that risk? Well, 2 ways. We can go online and use the STS Risk Calculator. This is very easy to do. We do this in every patient and record it. This takes about 3 minutes. Gives you an estimated risk based on a large number of patients in the STS database. But not everything's in there. So hostile mediastinum, calcified aorta, malignancy otherwise, these things aren't included in the risk tool. So these things have to be added in on top of the risk that you calculate. So it's not strictly a numerical risk based on the calculation tool. That's very important to recognize. It's important to recognize, we've got a paper coming out from the TVT registry actually next week where we looked at off-label use, and about 1 in 10 valves is used off-label. That is for indications that aren't strictly approved, but in which there was some judgment that the patient would benefit from having the TAVR. Now, I got to show you some Kaplan-Meier curves also. That's also a sign of manhood. So I'm going to show you 4. So 5-year survival after TAVR in inoperable patients. This is partner cohort B. You can see 93.6% mortality in medically managed patients. Again, 4 of the 5 survivors crossed over and had one form of AVR or the other. But take a look. The procedure that we're calling a success still has a 71.8% mortality at 5 years. 2/3 of those deaths are cardiac, 1/3 are non-cardiovascular. Symptoms are improved, but we're still looking at a very high-risk population. Surgical AVR, 5 years, equivalent in the partner study. Superior in the core valve study, and equivalent in the CERTAVI trial. So this is where we stand. The other thing that I think is very important for you to recognize is at 5 years, we see no signal whatsoever of structural valve deterioration. So we've taken these valves, we've beaten the hell out of them, getting them into the aorta, and at 5 years, they don't break down. Now, that doesn't mean at 7 years they don't. The surgical valve experience includes valves that have looked good at 5, but not good at 7. So we have to be aware of that as we move into the lower risk group. But take a look, and take a look at these aortic valve areas. They're the same, and actually as you get into some of the newer valves that are larger and have much lower gradients than surgical valves, you're looking, where'd Bill go? Well, one of you echo guys, listen, we're looking at estimated valve areas of 2.5 square centimeters. That's huge. That's unheard of in the surgical world. So if we're looking at newer, larger valves, we may be looking at results that are far superior to surgery, at least in terms of residual gradient. Now, when that's the case, if you get equivalent results in a lower risk population, the baseball rule is tie goes to the runner, right? Everyone know that rule? Yes? I did as a kid. The only thing is, if you look in the baseball rule book, that's not the case. The runner's got to get to base before he's out. And what does that mean? That means as we get into lower risk populations, you've got to do better than the first baseman. You've got to do better than surgery. So what has happened is over the years, if you take this risk spectrum, we started with the very highest risk patients, and we are shifting toward your left in a big way. We started with extreme risk, moved to high risk. Now we've moved to intermediate risk. So that brings up 2 things. First of all, what does high risk mean? Well, I mean, these are 2 patients put in the STS Risk Calculator. They're the same age, you get the same risk. Any question as to which one looks healthier? Well, that's a problem we face. We get, people think of TAVR, and so do we, as a cure for elderly, frail patients. Well, the truth is, probably half of those patients we started with are too frail to benefit from TAVR. Not too frail to undergo it, but a patient who's got moderate to severe dementia, a patient who's got lots of falls at home, patient who's got severe liver disease, their survival isn't going to be impacted. They were slated to die with aortic stenosis. Now they're going to die with a prosthetic valve. So we've learned to move away from that group. But there's another side, low-risk patients. Patients maybe my age who've got critical aortic stenosis. The data would say if they have a surgical AVR, they've got a 15-year horizon. So now all the little things we worry about with TAVR, small residual leaks, small stroke risk, these things may weigh heavily over the next 15 years. Bicuspid valves, asymptomatic patients, a different story. Isolated AR, very different story. And the stroke issue, a different story. I am out of time. I won't go into more details. I assume during the question session you'll grill me and we can have a further discussion. Thank you.